Good afternoon, everyone, and good afternoon, the panelists. Good afternoon, Min. It's afternoon at my end. I know it's good morning in some places, so I can say happy day to everyone. We're happy to have this. Everyone is excited at this program, and the plenary have actually really, it has heightened our spirits. So we want to welcome everyone here, and especially we have two guest speakers, Lorilee and Karen. We say thank you for honoring this, and we say thank you for sharing knowledge. And for all other people, we say thank you. For participants here, or let me say attendees, we will appreciate the fact that all your questions should be addressed on the poll. I'm just trying to summarize this presentation. The topic for to be delivered today is accelerating problem-solving capabilities of subnational staff, an evaluation of the ITCH methodology. And this will really take us deep into, it's going to serve as an eye-opener onto us. And then as listeners, as attendees, our questions should be addressed should be typed on the chat so that it will keep save time. And then we'll be having two polls, and when the time comes, we just have to answer them, and then we show the feedback to all of us. Once again, I want to say thank you for attending. We have two rapporteurs, Atahiru and Abdullahi Umar, and then we have can the support team introduce themselves, please? We have two support teams. I can only see Atahiru here as the rapporteur. The support teams, we're supposed to be having two support teams. Okay, the support team have mentioned, he has responded on the chat. Thank you for coming, and then we'll be able to, as of now, I want to just set the ball rolling by calling on Lorilee to open the session. Thank you, Min. We appreciate the fact that you're here too and setting us on track. Thank you. And over to Lorilee.
Thank you very much, Felicia. I am going to share my screen now. We too want to welcome you to Accelerating Problem-Solving Capacities of Subnational Staff, an evaluation of the ITCH methodology. We know that thorny, complex challenges abound in the important work that you're involved with in immunization and training. What if you had the opportunity to talk through your greatest challenge and have peer immunization training professionals from across the globe be able to talk through that challenge with them and have the other professionals share their experience and counsel in helping you address that challenge. For example, this is what Shalini from India had. She faced the challenge of low immunization coverage in her region, and to address that, maybe you, if you have a similar kind of challenge like Shahini, she wanted to face that challenge by doing training, more effective training of frontline workers on specific weak areas of immunization service delivery. How helpful would it be then to hear from your peers, like Shalini did as well, in an ITCH session, who acknowledged that they too had this common problem and shared what they tried? For example, a catch-up campaign that might be helpful where the healthcare workers focused on what had not been done, or leveraging existing adult education programs to educate the local residents on immunization. Or what about engaging strong key stakeholders, those advocates, politicians, health authorities, and in an immunization campaign to increase motivation and immunization awareness? Does this challenge that Shalini faced resonate with you? Do some of these responses? This model of presenting a challenge and receiving real-time sharing and learning by and with peers is the essence of the Immunization Training Challenge Hackathon, designed to accelerate that problem solving of subnational staff. So, want to know more about this model and how it can address participant challenges and find out about effectiveness? That's what we hope to do in this session, that we want to familiarize you with ITCH, how it was evaluated, who participated, what was covered in these sessions, and what I always say, the so what, or what happened as a result of these sessions. As Felicia said, we do welcome your questions and comments along the way, so do include them in the chat session, and at the end we will come back and address those. When I say we are a team of evaluators from the University of Georgia here in sunny today Athens, Georgia in the US. I'm Lorilee Sandmann, a longtime evaluator and professor emerita at the University of Georgia. I'm joined by my colleague, Dr. Karen Watkins, the PI on this project and really an eminent professor in learning, leadership, and organization development. And we are assisted by graduate students, advanced graduate students also from the University of Georgia, Beiji Lee and Songyeon Yang, as well as Cody Daly. Cody, the other two were from the College of Education, and Cody Daly is from UGA's College of Public Health, Department of Epidemiology. So we will share in this conversation today. So what is ITCH? ITCH stands for Immunization Training Challenge Hackathons. So they were part of it was an optional design element of the Teach to Reach certification course. The goal for ITCH participants was to break through these kind of thorny challenges I talked about, these problems, and enhance leading change back in their own context by learning from each other about immunization training, both the challenges and solutions. As you can see, they were 30-minute virtual sessions, and they were held in 2020. There were 17 of these sessions, 9 in English and 8 in French. 583 people participated in these 17 sessions. There was what we called a challenge owner for each of the sessions. There were 17 of those, and then 40 different respondents and 526 listeners. So as I indicated, the premise for the ITCH sessions was this challenge, the challenge. And people who applied for Teach to Reach, part of their application process was to identify and begin to describe this particular challenge. And so here you can see the elements of the rubric that the applicants, Teach to Reach scholars, use to describe their particular challenge. So you might think about a challenge that you face. Could you describe why it matters? What have you tried? What has been done? What solutions have worked? What haven't worked? Who or what can help you? What lessons have you learned so far? What has surprised you? Have you had any eureka moments? And what else might you need to address that challenge? I shared just a little of what Shalini was facing in India. And here you can see a representation of how she documented her challenge in the application for Teach to Reach. And she also then presented this at an ITCH session. So you can see where she talks about this challenge and why it matters and what she has tried, the lessons learned this far, and her eureka moments. So how does an ITCH session actually work? Well, it's what we call a 30-minute open-ended digital space of possibility. I love this description because it is not expert-driven. It is peer-driven. And here you can see the challenge owner describes the challenge vis-a-vis the rubric that I just described. And these sessions are moderated by facilitators, Teach to Reach staff who actually kind of set the container, they kept track of the time and so forth. And then you have this respondents who were responding to the challenge owner. And their role was not to say what the challenge owner should do, but rather what to share their experience. Something like, I've been through this, or this is what I have done. This is how it's been for me. And thinking specifically, how did it help how can we help that challenge owner? How can they help that learner? And then we had the observers. And so they listened and actually carried on very lively chats. So those were the sessions, the ITCH sessions, and the Geneva Learning Foundation, their funders, program developers, and learning scholars were interested in how did these sessions work, to evaluate these sessions and find out and do some exploration about what are the most critical training challenges facing those in the immunization global community. And to what extent can those doing this immunization training learn from each other in this open-ended digital space? And what was the impact? What difference did it make? And so we were commissioned as evaluators to address those questions, and specifically these 6 questions. Who were the challenge owners and respondents? What were the common themes or patterns in the challenges? What happened during these sessions? What kind of ideas were shared? Who contributed and in what way? And what results occurred then? The so what? What results did people who participated identify from these sessions? And how was it used to foster learning in the individuals, in the other attendees, and in the country teams? So we explored this data. We used the data from the Teach to Reach documents, the applications, the submitted challenges, and we listened to the ITCH session recordings, both in French and English. We conducted a follow-up survey of which 181 people participated. And we conducted 3 interviews with key ITCH stakeholders to get their perception of the impact of ITCH. And we did this by looking at the data through thematic analysis, statistical analysis, and additional machine learning algorithms. So with that, we'll want to now share the results of this evaluation. Who were the challenge owners and respondents? And with that, I'm going to turn it over to Cody, please.
Hello, everyone. Thank you for being here. Hello, everyone. Thank you, Dr. Sandmann. I have an echo coming through your mic. So just before we get into who were the challenge owners and respondents, I wanted to get a sense of the overall broader scale of the Teach to Reach. We have records for about 3,700 folks who participated in the Teach to Reach, who were all invited to participate in the optional design component that was the ITCH sessions. 303 submitted challenges describing their challenge, problem, or dilemma that they were trying to solve, as well as some other pertinent details that Dr. Sandmann mentioned. Of all these applicants, the 300 who submitted the challenge were for the pool that were used in each session for presenting their challenge. Of all the ITCH sessions, 583 actually attended at least one of the sessions. Of this, about 600 ITCH attendees, 421 or 72% actually went on to receive their certification from the Teach to Reach program. Next. Yes, so if we look at the individual attendance for each of the ITCH sessions, we can notice some good repetition in the attendance for each individual. For the French sessions, there was an average of about 116 participants in each session, and each person attended on average about 2.4 sessions, with 84 participants, or 22%, attending 4 or more sessions. Next. Back one, you skipped one, I think. Yeah, so for the English sessions, there was the same repeatability that was found in the French sessions. In this one, there was an average of about 54 participants in each session. Each participant attended on average 2.2 sessions, and 35 of them, or 18%, attended 4 or more sessions. Overall, there was an average of 2.3 sessions attended by all people, with 119, or 20%, attending 4 or more of the itch sessions. Next. So from our 17 itch sessions with the 17 participants presenting their immunization training challenge, each participant and attendee was invited to speak on their experience with that particular challenge and how it might have worked out. During these sessions, there was a total of 59 verbal responses to the challenge presentation, originating from about 46 individuals, and 6 of these 46 were actually challenge owners themselves presenting to another challenge owner's problem. When looking at the main country of focus in their work, challenge owners mostly represented the Democratic Republic of the Congo and Ivory Coast. When looking at the organizational affiliation, our challenge owners mostly were Ministry of Health staff working either at the subnational or the national scale. The respondents represented Nigeria a little bit more, but also the Democratic Republic of the Congo and Ivory Coast were represented as well. Consultants made up a greater portion of the respondents compared to the challenge owners, but the Ministry of Health staff, both at the subnational and the national scale, were both represented. Next. So of those about 300 challenges that were submitted, we used some machine learning algorithms and basic natural language processing analyses techniques to break down some of the kind of key concepts that were within these challenges submitted. And we generated these word clouds within. So as you can see, we have the English on the left and the French on the right. It can be noted that a lot of the problems discussed problems with personnel and staff and healthcare worker staff, community hesitancy, community engagement problems, data issues, and data quality. And a lot of these get into further with, I think, Bei-Shi Lee is going to speak on them.
So we would like to hear about your experience if you've been a part of one of these sessions. So please go to the polls on your site and please tell us your experience with sessions like these. Did you participate in an itch hackathon as a participant of Teach to Reach? Did you participate in a breakout session in level 2 certification? Or did you participate in a lightning session in a peer hub? Or maybe you didn't participate in any of these sessions, and so you really are interested in all the dynamics of this. So please go over to the poll, and I encourage you to indicate your level of experience with sessions like this. So please. I'm looking.
The polls are out. I hope we can all view them. So kindly click.
So go to the polls to the right of your chat. I'm not seeing results or anything yet. Felicia, do you know how?
I've put them all out. I hope we can all view it. Can you view it?
I can see the, in the polls, I'm looking at the 4 options, but I'm not.
Yes. So that's what we are
Yes,
expected
yes.
to click. Kindly click and let's
Yes.
have the results.
Yes, so far we have around 15 people who have voted in the room. So most of the votes are actually concentrating on I have not participated in any sessions like this. And the next option is I participated in the each hackathon as a participant in Teach to Reach Level 1. So that's the results that I'm seeing right now. And I hope that Lorilee, if you're not able to see that, those are the results that are being shown right now.
Very good. Thank you, Jha. We really appreciate that. So we have kind of both ends of the continuum of people who have participated and those who have not. So as we go on and listen to what happened at these itch sessions, those of you who were in those sessions, you can see if it was similar to your experience, and we'll describe those to those of you who have not. So Beiji, we will go on to you to talk about what actually happened in the itch session.
Thank you. So in the 17 itch sessions, we listened to challenges related to training, data management, community engagement, and much more. In the 17 itch sessions, we received 63 responses from the participants. The respondents usually started with affirming that the challenge submitted by the challenge owners were also presented in other areas of the world. After confirming the prevalence of the submitted challenges, the respondents proceeded to share their own interpretations, observations, and experiences related to the challenges. Next, please. So in many instances, they started with their observation of the healthcare workers, trainers, and the trainees. In general, healthcare workers are doing great work and they want to be appreciated and receive rewards or recognition for their hard work. However, there needs to be a proper hiring and a training process for healthcare workers to be successful in the field. Next, please. Each respondents offered diverse experiences on how to improve training and supervision to better support the healthcare workers. First, they advocated for a whole system and a bottom-up approach to training. Second, accessible e-learning models and practice-oriented training should be promoted. E-learning is especially relevant under the current circumstances. Third, ongoing support, including supportive supervision, mentoring, and on-the-job training is critical in ensuring the implementation of training knowledge into practice. Next, please. Regarding specific training topics, the respondents shared their experience in 4 areas. First is data management. Data management continues to be a prevalent issue in immunization campaigns. To increase awareness of data management, local health zone officials should be invited into dialogue on data quality issues. Microplanning is critical in ensuring immunization campaigns reach each community. Respondents share their experiences integrating training and community engagement into microplanning. Cascade training is a popular type of training method in immunization campaigns. Medical professionals and training specialists should come together to create an easily cascade model. Facilitation support and supervision should be provided in the lower level. Cross-border meeting is essential in determining the needs of each region and fostering collaboration in cross-border immunization campaign. Next, please. And the final topic closely related to immunization campaigns is to leverage community members to raise awareness and increase coverage. Respondents share that vaccine hesitancy was a common challenge. Communication is the key to successful immunization campaign. When planning the campaign, key members like village leaders and spiritual leaders from the community should be involved to help with the campaign. Healthcare workers could demonstrate to them that vaccines are safe and they were properly trained to administrate vaccines. So that is a summary of what happened in the 17 itch sessions.
Thank you, Beiji. For those of you listening to this, if you might think of your own challenge, could you write a headline for your challenge? And would that challenge fit into one of these 4 categories that the others who participated in itch, their challenges fit into one of these 4 categories? Be interesting to see if yours are consistent with these challenges that were found across the challenge owners for the itch sessions. But now we're going to go on to about, based on the evaluation, so what? What happened as a result of people participating in the itch sessions? What results do itch participants identify from these sessions? How do these challenges addressed? Can they potentially improve immunization outcomes? And then what learning was fostered? And for this, we'll turn to Watkins.
Thank you. It's good to be here with everyone. You know, one of the things that is very important to the Geneva Learning Foundation, and certainly to those of you in the field, is, you know, really the impact of this work. It's not so much doing the training alone that matters. Is it useful? Does it in fact change anything in healthcare? And so we were particularly interested in that. Cody shared with you data that was primarily coming from the application and some of the demographics of the population that we had. And Beiji talked to you about the data that we had from transcripts of the itch sessions themselves. And what I want to speak to you about is some of the results from our survey. So first I'm going to give you the sort of the headline, if you will, and then I'll share some of the specifics. But essentially what we saw across all of these data sets is that these open-ended, non-teaching designs really created a space for the ability to talk about a range of training and immunization problems. That the people could talk about everything from a problem in, personnel working with a particular healthcare population to something as broad as reaching coverage throughout all of India. So the range of possible problems were as great as the range of problems that you face. So that open-endedness was a powerful part of the impact. The 4 major challenge areas that Beiji talked about seem to resonate with many. In fact, in the transcripts, we would frequently see that the first comment that people would make is, yes, I have had that experience, or we've had that experience in my country too. And so then you get respondents from all over the globe who could share the helpful experiences that they've had. In the survey that Cody talked about, going to 181 respondents, we found that 88.5% said that the sessions were useful, and 76.3% of those gave it the highest that they could, which is extremely useful. So very, very satisfied participants, I believe. And the other thing that we asked in the survey was whether or not people felt they could actually implement or incorporate even immediately what they had learned in the sessions. And 65.2% felt they could, which I think pandemic is a pretty powerful outcome. So we also felt that the itch sessions are effectively scalable. They allow a large number of people to participate, 586, and at the same time can deal with individual problems that others may relate to. It was intriguing to us that so many people came more than once, and quite a few came 4 times. Ultimately, the program reached the right audience. It got to the frontline workers, people working in the training trenches, if you will. And I think that's another level of impact. Next. So in the survey, the other question that we asked, I've already shared with you about that we did in fact find it useful and implemented, but also and people talked about follow-up. One of the things that struck us is that of the options we offered, which were the options that were used in level 2 certification of working with peers in a problem-solving setting, working one-on-one with a subject matter experts or feedback clinics, the one that people rated the highest was what happened in the ITCH sessions, and that was working with peers in problem-solving groups. Next. Also, we asked if people had encountered any difficulties, and I've been noticing in the chat people having difficulty with sound, sometimes not being able to see the screen and so on. And so we really thought issues of technology or connectivity would be the highest. But it turned out that sort of a fluke that, only well, actually about half of the respondents said that they had run into some difficulty. And the most frequent difficulty was timing. And so a number of people, I think it mentioned that it just turned out that the sessions were on Monday and quite a few ministries of health hold mandatory Monday meetings. So that was an interesting thing to learn and easily fixable. Really only a very tiny number of people said that the challenge was outside of their experience. And it was just something we were looking at as well. Next. So we had a number of open-ended comments in the survey, and of those, 3 things stood out to us. Again, we can't say enough. The most important thing clearly is that learning from peers was the most important outcome for people, that this experience was so rewarding. That we learn by helping others and by sharing with others, they said. And I like this comment, ITCH sessions are really support sessions for me. And I think that really speaks to the power of this kind of learning. Second, they said that learners felt that just being exposed to the new technologies, that the ITCH session itself was something that they could take back and use in their program. I appreciate the power of technology and organization learning and training at scale, was the comment made. Next. So they learned from the solutions as well. So they got practical ideas, they could hear divergent views, but they also liked the idea that in the listening, they could break down the solutions into manageable steps and get feedback that they could then use to strengthen their own programs. So across all of these responses, we get a sense that learners really had learned something useful. And it was also clear to us that this optional activity blended well with the rest of the Teach to Reach experience, and so augmented it in particular ways. So in the process itself, the learning from each other, the seeing a virtual problem-solving session in action, and the sense of community that people spoke about, really that partly emerged from feeling that the problems that each brought to the session were shared across country borders, but also just having the experience together was something that they could learn from and replicate themselves. Next. Next, there we go. This is important to us in particular because research suggests that there's an inverse relationship between the richness of media and the scope of media. In other words, face-to-face communication or talking on the phone is a very rich way to communicate, and usually the kind of large-scale methodology of 600 people in a session and so on is that kind of scope tends to reduce the richness. ITCH, through the open-endedness of it, the sort of the community building process in it, challenges that. So you can have actually high scope, but also high richness. And I think that's really important. Next. So those are our primary findings from the survey and other sessions.
So now we encourage you to go to the polls again and tell us, were you surprised by these findings? The findings of learning from peers, of learning about technology through this, learning about solutions. Again, is that a surprise to you? Some part surprised you, fairly surprised, or very surprised?
You have to scroll down in the polls in order to get to this particular poll.
This is poll number 2.
Colleagues, kindly take in the second poll.
Yes, this is the second poll.
It's there. Were you surprised by these findings? Not at all surprised, just what I expected. That's option 1. Option 2, some parts surprised me. Option 3, fairly surprised. And the final one, very surprised. Please go ahead and click and we get the result from Min. Thank you.
Yeah, and just to share, we have 12 people who voted, and 50% of you actually said, not at all surprised, just what I expected. I imagine some of those are each participants, and we'd love to hear you. Maybe, you know, Karen Lorilee's findings, how do you think of this? So consider share audio and camera to join the panel and maybe ask your questions to the team. And we're getting more results, but not surprised at all is still leading the chart. I'll give the floor back to Karen or Lorilee.
Lorilee, please, and Karen, we had some people that made contributions, about 3 people that gave a point. Should we wait till after this presentation or we just address it?
Well, we'd just like to follow through on these lessons learned, and then I think part of their contribution can certainly add in.
Right.
So let's turn from those things that we thought we learned to what we had some takeaways, and then then you can add your takeaways as well. So what can we take away from all this evaluation and this experience to our own practice? Well, one of the things that we as a team are suggesting to take away from this is to continue to build on this network building. One of the lessons learned through this evaluation was that immunization training professionals clearly said they wanted to build their social network. They asked for contact information of participants. They rated these peer learning groups as their most desired follow-up for these sessions. And one person even wrote that about the importance of not dying in silence, about working together. So many of the solutions that were offered were probably not new and simply reminded people of recommendations that were coming from WHO and other places for dealing with these commonly reoccurring challenges or problems. But it was the connections, the networks that were built that were empowering and instructive for people who participated, particularly connections within a country to support and counsel each other in addressing training and immunization challenges. Network building is about us connecting like roles, people like ourselves. But another important lesson learned was about connecting to those in our community outside of ourselves. And I saw Emmanuel add that, you know, trying to engage local leaders is one of the challenges. And that's why this role of being a boundary spanner is so important. Almost all the solutions that were provided or experiences that were shared had some component of community engagement with them to engage key stakeholders critical to the success of the immunization coverage goals. So the lesson learned is to affirm and commit to and to really strengthen your roles, which you may do automatically as boundary spanners, representing and speaking for the health departments, but partnering in mutually beneficial ways with with your local leaders to ensure that your message is being heard and accepted in the communities. And we know this is a really complex role, to know who to partner with, how to establish these partnerships, how to maintain these relationships, how to get these relationships operative and creating an impact. But it really can result in the shared leadership and the sustainable and actionable micro plans to reduce vaccine hesitancy and get more accurate information and data and accountability toward population immunization. Another lesson learned was about program design, and I'll throw it back to Karen for this one.
There's a question, a comment in the chat of asking for you to define boundary spanners. Would you do that?
Yes, I'll do that. But it's people who are connecting to organizations, and in this case, you're connecting the health departments or the professional organizations with the community. So you're spanning your boundaries. You understand the what's going on. I always talk about these people being bilingual. You have to know the language and the mores and the traditions and so forth of your organization, as well as the community you're working with. And you can be the translator of that. So a boundary spanner is a person who links organizations.
Thank you, Lorilee. I am actually going to suggest that we just skip to the end because I know we only have 4 minutes left, and if I understand from Felicia that there are people with comments and questions, and I'd love to get to those if we could at least get a question or two.
Felicia or Song Yong, do you want to bring forward those questions, please?
Song Yong did it.
You have addressed, but someone talked about challenges, adequate involvement of traditional leaders, community leaders in training activities. They're only seen as, oh, you go and dialogue with them or advocacy, but you don't really involve them in the training activities. We thought training is just it's more of you have to write or you are educated. Secondly, the training plan. Someone said the training plan should be bottom up, not from top down. Much time is not allotted to training at the grassroots level. We just rush there to say there will be training tomorrow and don't finish. We particularly cited a state in Nigeria, Adamawa State. Then the engagement of stakeholders. Thank you, and over.
Karen, do you want to start out with that?
Well, I think those are actually good suggestions. I think that the idea of boundary spanning is literally that people create reciprocity, that there's mutual working together to mutual benefit. And so the idea of involving community leaders in the training, I think, is superb, because that is the way to make it more intrinsic, make people understand the needs more clearly, so that the health worker and the community leader are in dialogue with one another. So I love that idea, actually. And
further, like you say, Karen, it starts with the planning.
Yeah.
So community leaders can be involved and help participate, involved in the training, certainly in the micro plans and so forth, and involved with the training as well.
Right, and Emmanuel's comment about the problems of connectivity and for those that need the training most, I think is really a challenge, particularly in these times when face-to-face is so, dangerous. So I think, solving internet connectivity problems is outside our scope, but certainly, to the extent that you can use telephone and other means, it might be time to, rethink even paper as possibilities. So at any rate, that is really a strong challenge, I believe. I wanted to make one other comment. Another comment in the chat I noticed was about the inadequacy of cascade training as it gets down to the lower levels. I think that is a legitimate concern, and so I think that how you when you build your plans, how you're going to shore up the lower levels is a really important consideration as part of the training plan, because that is the greatest weakness.
Unfortunately, it is 11:45, and we would love to continue this dialogue with some of you if you're interested. So if, our goal today was to help you become familiar with itch, its effectiveness and the lessons learned. But if you wish to continue a dialogue, you can contact Dr. Karen Watkins at the University of Georgia, uga.edu. My contact is in the profile information as well, and we welcome that opportunity because we know these pandemic times call out for this accelerated problem solving. And we hope that this presentation was helpful in starting you in thinking about these accelerated problem solving strategies.
Thank you so much, Lorilee. Please, a quick one. Someone asked then, how can we solve this training problem? Can we have a quick one on that so that it will be our take home?
The question is how to solve the training problem?
Yes.
Were we talking about vis-a-vis technology? And we were saying, I think part of the conversation was about the use of technology, or training problem about involving community leaders. I think it's a little broad. And Karen, did you want to say anything about that?
I agree. I don't know what the training problem is. I'm sorry, Felicia. So I can't really speak to it. I'm sorry.
No, he was actually talking about all these problems that have been highlighted. Yes, bottom-up approach involving traditional leaders, that the lingering problem now, how can it be solved? He said training is key, but the concern is how can we solve it? What's the next step? Maybe I put it that way, the way forward, the next step.
Well, I actually think, since so much of this is bound up in community engagement, that part of the next step is helping build all of our capacities to do that better, and to really use that as a framework for which we think about planning, training, the immunization coverage, and the data management and so forth. We do it collectively. We do it collectively within our communities, and we also do it within our professional community of immunization professionals.
Thank you so much.
It's been our pleasure.
Thank you. Thank you.
Thank you. Thank you, Lorilee, that have been able to grace this session. We've taken notes of the questions, and for references, you'll just get to colleagues to go to the Dropbox and download this presentation. Like Lorilee said, if you still have more concerns, we can actually link up with them. I know for those that have done a Teach to Reach level 1, level 2, we have been through this topic before. But again, notwithstanding, this is another dimension. They have given us an exposure to the research conducted, and we can see that training is key, and we really need to do something about it, solve the problem, and there is a way out, and we will get results. Thank you so much once again, colleagues. Thank you, our presenters, and we say have a good day. Min, over to you. Min?
I think she's at the networking session, but thank you so much, Felicia.
All right, then. Thank you, and enjoy the rest of the day.
Thank you.
Bye. Yeah.
Appreciate your facilitation.
Thank you so much.